Good afternoon, everyone. It is my great pleasure to welcome Dr. Sandeep Laroia, and he is Associate Professor of Radiology and Oncology at University of Iowa, USA. And he has specially come here to speak on the topic Endovascular Management of Hemoptysis, a review. And he is the Vice Chair of Department of Radiology at the University of Iowa, and he has a vast experience of cardiovascular and oncology interventions. His special interests include specialization in embolization, and he is also the founder president of Juggernaut Life Sciences, a medical device company based in USA. He has authored many papers and is nominated in the top 10% of the US physicians. And he has also been a part of Cardiomergen since more than a decade, and he has given various talks before this also. And I'm very much thankful to Dr. Sandeep, and I hope you will enjoy giving this talk today.
So this topic is very kind of niche topic, hemoptysis, but we all come across hemoptysis case quite frequently, so I thought we will talk about that. So let's start with this case. So this elderly person came from outside hospital, OSH transfer, and then MICU is requesting an IR consult, and as is typical in the consult text just written massive hemoptysis. So what's the definition of massive hemoptysis? How do you define? Is it by when we bleed, when there is trauma, when we lose?
More than 200 ml?
So from students' point of view, typically they want to know, some numbers. So we will talk about massive hemoptysis, what lab work we need to do, what we want to look into the history when we talk to the patient, and other imaging and issues. And then there is urgency to intervene. So as Dr. Saab said, massive hemoptysis is 250 ml, which is actually a very small amount, okay? Because typically healthy patient can lose, 1.5, 2 liters of blood, young patient, and still they are compensated. But why we are talking, just 250 ml is massive, okay? So anywhere between, when we talk to the patient, they will usually tell you कि 1 चम्मच खून आता है, या रुमाल में भर जाता है, या 1 कप भर गया जी, या बाल्टी भर गई, इस तरह की डिस्क्रिप्शंस आती हैं. But actually if they are losing about 250 ml, and then we will go into the complexity of that is massive hemoptysis, okay? If they are losing, which is about 1 cup, okay? So it's very small amount, but it's 250. And this is a functional definition because this amount can cause a life-threatening condition. And why is that? But we will come to that, But since this amount is so small, so you don't want to waste time in looking at their HNH trend, Typically we want to do the HNH trend, But in this, this won't get reflected. It's such a small amount. Typically CBC will also not change much, So serial HNH is not helpful for making a decision, when to intervene. But what we want to check is we want to make sure there is no coagulopathy, okay? So they are not bleeding because, dengue or something, platelets are low, or there is some other hematological issue. Medicine on board, oral anticoagulants. So we want to check those things first rather than wasting time on CBC and HN. The most important question from our side, from interventional radiology side, is we want to know whether the right side is bleeding or left side is bleeding or both sides are bleeding. Because our management will depend on that, because then if we know which side is bleeding, then we can very quickly go to that point only and not waste time looking around. So our priority is to know which side is bleeding and how do we go to that point. So we will talk about that. Then typically any chest patient, any pulmonary patient, these are the basic investigations. They will get a chest x-ray, okay? They will get a bronchoscopy, and if things permit, then probably a CT chest or maybe a CTA, okay? So we will look into their importance. So this is a very typical chest x-ray of a hemoptysis patient, meaning you won't see anything, okay? The x-ray is not going to help you in any ways, Okay, so again, don't waste time in getting chest x-ray, etc. If it's available, very good. But you don't want to say, first get the chest x-ray and then we will proceed if they're bleeding that much. So basic workup, chest radiograph probably is going to be there because these are sometimes, acute on chronic cases. They might be bleeding a little bit, 1 teaspoon here, a little bit there, and now they are coming with massive hemoptysis. So in their bag, there may be a chest x-ray. So you want to see that. But most often, as I said, it would be normal. And then there are studies, which went back and look into the x-rays, and those were positive only in about 50% cases. So don't waste time in getting, read or, trying to get, very minutely interpreted. And similarly, bronchoscopy, the range is from 50 to 93%. So you can see very wide range, And the reason for that is, when they are massively bleeding, you may insert a bronchoscope, but they're bleeding so much that you won't see anything. And it may be hazardous to do that, you may lose airway and things like that. So again, bronchoscopy, if you can do it, very good. Because if you see a lesion, you can inject something, you can do cautery, you can stop, But if you can't, again, don't force that. So the important thing, if you can get a CTA and especially CT angiography, then probably that is more useful than anything else, okay? Because now we will see things which are not visible on other investigations. It will detect vascular lesions for sure. It will detect tumors for sure. And in 63 to 100%, you will find some abnormality. And this is more than bronchoscopy. So if there is a chance, try to get a CTA first. CTA is better than CT. And then CT and bronchoscopy are complementary. Suppose you see, lesions are on both sides of the chest in CT scan, you still need to know which side is bleeding, So if time permits, then do a bronchoscopy. So this is a very classical picture, when we see acute on massive hemoptysis, acute and chronic hemoptysis, there will be some findings on the CT. And here we see that, the left side here, that is showing consolidation. And if we see serially, many times you won't see those florid changes like we are seeing here. You will see on CT, you will see subtle changes like this, because this is blood which is settling in the alveoli. Okay, so diffuse alveolar opacities, when you see that, shows this side is bleeding. Cause may be anything. It can be a tumor, small tumor, endobronchial tumor, or it can be a vascular lesion. That's a different thing, but it will show some indication. So as you can see, this side is totally normal, but on this side we see all these ground glass opacities. So this is blood settling in the alveoli. And then other thing we want to pay attention to, these are the mediastinal pictures. So lung pictures are just going to show you those alveolar opacities, nothing more than that. So it will just tell you right side is bleeding or left side is bleeding. If there is a tumor, very good. But what we want to look into the mediastinal windows. So these are different windowing. Okay, so we are looking at the soft tissue, and what we are looking at is these big, nodular or tubular shadows. So the bronchial artery will look something like this. So that is coming from the aorta, and we typically want to see that because that would help us when we go for the actual management. And again, more than axial CT scan, if you get a coronal projection, that probably is better, because then you can very clearly see these serpiginous opacities. These are the vessels, these are the bronchial vessels. And then we want to look at the pleura. If pleural space shows, these again serpiginous opacities, these are usually abnormal, and then there is importance and interpretation of that, why we want to see that. So again, some measurements, if somebody is interested, so bronchial artery measurement should not be more than 1.5 millimeter at its origin. If it's more than that, then it's abnormal. Whether that person is bleeding today or not, he is going to have some problem in future. So anytime you see that 2 millimeter size, that is abnormal. And then hypertrophic, the normal vessels you won't see. If you take a CT scan of a normal person, normal bronchial vessels probably you won't see. If you start seeing them, that is abnormal. Okay, so that is important. And then lastly, if nothing is available, there is no time, talk to the patient. Many patients, especially if they are chronic TB patient or there is a tumor for some time, so they know their body and they can tell you, Doc Saab, left side is now gurgling or whatever, so they can tell. So more than any investigation, if we simply ask the patient, do you know which side is abnormal, they can give you some indication, and we will see that. And this has been, studied very well, and this is a fact. Now we come to urgency to intervene. So we have defined 1 cup, 250 ml of blood is important, quantity wise. But more important is over what period of time that's happening. Okay. If it's happening for 16 to 48 hours, over 2 days or so, very less mortality, only 5%. But if that's happening very suddenly, patient is just, pouring out blood. So that 250 ml happening in less than 4 hours, 71% of these patients will die actually. Okay. So if you see that amount coming out, we need to intervene quickly. Then some of the pearls are, sometimes, we think, that not doing anything perhaps is the best thing. But in this case, probably you want to be a little bit more aggressive, especially when there is massive hemoptysis, because mortality rate is pretty high, 50 to 100%, based on what kind of series you are seeing. And the second thing which is important is, since we already established this is not a big amount of blood, these people die because of asphyxiation. Okay, so the bronchial tree has capacity of about 300 ml. Okay, if you look at the whole bronchial tree. If you put 250 ml of fluid in that, any kind of fluid, whether it's blood or water or saline, drowning, etc., that is enough to kill the patient. Okay, so these patients die from asphyxiation, not from hemorrhage. Okay, so giving them blood transfusion, giving them saline or dextrose or whatever, that's not going to help them, because they are dying because of asphyxiation. So aspirating it out is probably the first thing we need to do. Then surgical mortality, sometimes, we have to do surgery if other options are not there, but mortality is pretty high. So because, difficulties with intubation, they are already compromised patient. So if we want to do a surgery on these sick patients, mortality rate is up to 40%. And most of them actually are pretty bad risk patients because they are chronically sick because of something else, infection, TB, fungal infection, neoplasm, etc. So then we come to, I think this is probably the most important slide, because typically when I ask my first year residents, what is the source of hemoptysis, almost 90-100% of them, they say it comes from pulmonary artery, because that's the big vessel in the chest, so they will always say it comes from the pulmonary artery, but actually reverse is true. So most of the bleeding is coming from bronchial artery. Okay, the pulmonary arteries very rarely cause problems as far as hemoptysis goes. Okay, so whenever hemoptysis is happening, we want to look at the bronchial arteries first and everything else later. Okay, otherwise, the bronchial arteries don't play much role, but in hemoptysis, they are central to the problem. Pulmonary artery origin is rare, as I said, but it can happen in specific instances, what we call Rasmussen's pseudoaneurysm. So basically it's a TB cavity, and then because of TB, erosion is happening, and that erosive ulcer is going into the pulmonary artery, and then pulmonary artery is bleeding. Okay, so it's rare if we look worldwide, but in specific instances, especially in country like ours where TB is rampant, we want to keep that in mind. So it can be pulmonary artery, but in a very specific instance. Then sometimes it happens in intensive care unit settings, we are putting a Swan-Ganz or, some kind of line, and that line kind of perforates the pulmonary artery. Then hemoptysis can happen. Or there is a malformation. Then pulmonary artery is feeding that malformation. Then we want to intervene from the pulmonary artery side. Okay. So this probably is one important thing. I won't go over the list because this is not even half of the list of causes of hemoptysis. If you go to Harrison, there are 20 more causes for that. But basically, we want to remember infection. And in infection, we want to remember TB or chronic pneumonia. And then in Western countries or developed countries, TB incidence is less, but cystic fibrosis is very high. So most of the patients actually who come to us is from cystic fibrosis, not TB. So just difference in, country to country. Other things, as I said, they can happen. One thing we should not forget, cardiac problems can also cause hemoptysis because of back congestion. Okay, so always think about that too. And then, of course, many a times we don't find any cause. Let's skip over this. And this pathophysiology, you all know, then, in acute or chronic pulmonary disease, why bronchial arteries hypertrophy? Because pulmonary arteries are getting vasoconstricted, lungs need blood supply, so bronchial arteries are getting bigger. And when they get bigger, after a certain time, they can't handle that much pressure, they rupture, and then they bleed. This is the basic pathology. So history of bronchial artery embolization actually is pretty old, since 1964 people have been doing that. It started in France, then spread to other parts of the world. In Asia in particular, there are several centers in India itself, where it's done quite frequently for hemoptysis, and has been done, for 2-3 decades now. But in countries like Taiwan, Malaysia, China, it's a very common procedure. When we talk about angiography, in any bleeding condition, there are few things we want to see. So when we inject contrast in the arteries, either we see leakage of that contrast out, that's how we identify there is bleed, or we see some other signs which tell us, that this artery is abnormal and we need to target that. In hemoptysis, all those signs actually are not reliable for a few reasons. So as you can see, the bronchial arteries are small to begin with, and now they are feeding into a field which is constantly moving. Okay, even under anesthesia you can't stop breathing. Okay, you can slow it down, but you can't stop it altogether. So there is always some motion artifact. And third factor is, whenever this is a small amount of blood which is coming out, so you put a drop of ink on a piece of sponge, it just spreads out, you don't see that, and same thing happens on the angiogram. And that's the reason we want to know which side is bleeding, because on angiogram we won't get that idea. Okay, we won't see a big blotch of contrast leaking out, so there is no help to us. Okay, so we want to establish that before going in, that this side is bleeding, I want to intervene on this side. Okay, I may see some sign, based on experience and expertise, but most often, you won't see any sign on angiogram. Okay, so that's why we ask the patient, we do CT and all those things. So this is what we call, in arch aortogram. So our catheter is here and we are injecting into the aorta. So aorta is getting filled. And these branches, these are the intercostal branches, as you can see. And on the left side, these are the bronchial arteries. We see these intercostal arteries here too, but because of vasoconstriction and all, they are not very well seen, and also the projection. But the bronchial arteries will look something like this. So they are very faint. It's hard to see them. Then a little bit on the bronchial artery anatomy. If you look into the whole body, everybody has, we are taught in the books is, the classical anatomy for everything. Okay, but each person is different. Everybody's vascular system is different. Mine is different, yours is different. The general trend is same, that celiac axis will come at this point, SMA will come at this point, but as soon as it comes out, it's like fingerprints, everybody is going to be different. But still, they follow certain path. Bronchial arteries are bad in the sense that they have maximum variation in their origins. They have maximum variation in their branching pattern, So they seldom follow a definite path. So you need to know quite a few variations of these. Only then you will be successful, because each person you have to find, differently. But basically we divide them into four types, and type 1 is most common, which means that there is one bronchial artery on the right side and typically two on the left side. That's most common, but it only 38 to 40% cases. And type 4 is rare, which is the reverse of this, that there are two bronchial arteries on the right side and one on the left side, and then in between. So this is what we see when we inject a bronchial artery. So again, the reason we need to know that most of the hemoptysis happens because of bronchial artery, because the route to get to that artery is different. When we want to go into the bronchial artery, we are cannulating the arterial system. When we want to go to the pulmonary artery, we are cannulating the venous system. Okay, so we need to know that. Okay, so otherwise, we will go to the venous side and we won't find, because incidence of hemoptysis is less because of pulmonary artery. So we need to go to the arterial side. So that's the importance. Then the second thing is, we know that anytime they are bigger than 2 millimeters, they are bad. Okay, so if we see an artery more than 2 millimeters, we need to do something about that, because if it's not bleeding today, or if the bleeding is stopped, he is going to come back, so something needs to be done. And very simple measurement, you don't even have to measure on a screen or do any specific software. If the artery is bigger than your catheter, it's abnormal. Okay, because then it's definitely more than 2 millimeters. So you see an artery bigger than your catheter, that's bad. And then this is again, we are cannulating the bronchial artery on the left side. And now we know that on the left side, the most common pattern is 2 arteries, okay? So which is reflected here. So this bronchial artery is supplying the left middle and the lower lobe, okay? So we are missing the upper lobe, So if on history or CT scan or bronchoscopy, that, person was bleeding from the upper lobe, left upper lobe, you see this pattern, you do your intervention embolization here, you're not going to cure him because you're missing the other artery. Okay, so always make sure that when you inject the bronchial artery, you should cover the whole lung. So that's the point of this. And this is how sometimes it would look like, So this is a very, very, sick patient, cystic fibrosis actually. So chronically they have been bleeding, off and on, and bronchial arteries are so large here, and these are all, abnormal bronchial patterns. So this is neovascularity in the lung. So bronchial arteries are trying to compensate for pulmonary artery problems, so they have proliferated. So you see the proliferation here. And this branch, which goes to the upper side, this is actually an intercostal branch. So we don't want to intervene there. We want to intervene into the bronchial artery path only. And this is another example. So we know from that CT scan that when we are trying to read that, we also need to pay attention to the pleural space. If we see big vessels in the pleural space, that means there is a collateral pathway, So intercostal arteries are back feeding into the bronchial artery now. Okay. So here we are seeing those, jumble of vessels, and they are feeding back into the intercostal arteries. Okay. So here you may not be able to do your interventions from the bronchial artery side. You may want to go to the intercostal artery side and block those. And these are some of the technical things, which are useful for interventionists like us, what kind of catheter, what shape of catheter, things like that. So there are specific catheters also, but we can use, our typical coronary catheters too. We talked about this, we may or may not see these signs, but some of the things which are important from intervention point of view is, if there is a shunting into the pulmonary vein, okay, or in pulmonary artery, and we will see what happens if that happens. So this is an example here. So we are injecting into the bronchial artery. So our catheter is here. We see that neovascularity here, and we actually see this bleed happening right into a bronchi, So this linear structure, so contrast is getting pooled there. This is rare, but sometimes you see that, And this is what we will see. This is the neovascularity. You see these blotches of contrast, and here is this pseudoaneurysm. Okay, so this small nodular opacity actually is a pseudoaneurysm which burst and was causing hemoptysis. And this is what looks after embolization. Okay, so after embolization, we have eliminated all those areas of neovascularity. We have eliminated that area of pseudoaneurysm, and this is what is left. Okay, so this is bronchial artery. So a little bit of technique here, so you can use various things. You don't have to be specific or buy very expensive embolic material. If you have gelatin sponge, gel foam, you can cut particles of that and you can use that. Very inexpensive, very cheap, available almost universally. But ideal is if you have PVA particle, polyvinyl alcohol particles. So these are specifically made for these. They're about 300 to 500 microns, and their advantage is that once you inject them, they stay there forever. Okay, gel foam dissolves after some time, so person may come back to you. But if you put these PVA particles, then it's almost permanent. At least that vessel won't bleed. Something else can happen. Coils, which we typically use for other places, in lungs you don't want to use that. Okay, for a variety of reasons. One is you can't push coils very distally, and the bleeding is happening distally. Okay, and secondly, you put a coil, now you have closed the door, because this person is going to bleed again because you haven't gone distally, and now because of coil you can't cross that. So coils is last resort. You have to do something, you don't have anything else, then put a coil, but not as a first choice. Only, and I will show you the example, only place where coils may have a role is in bronchopulmonary fistula, and the size is important because of the anastomosis and various studies. This is the size of the vessels and things like that. Okay, so we talked about proximal occlusion, distal occlusion. So this slide is important. So we are injecting into the bronchial artery here. Okay, we see the neovascularity here, and now we see this neovascularity, and something is going back towards heart. So this is bronchial artery, and this is pulmonary vein. Okay, so this pulmonary vein is going back into the heart. So this is a bronchopulmonary vein fistula. Okay, now the problem is if you inject particles here and small particles here, they may leak back into the pulmonary vein. Okay, and when they go into the pulmonary vein, they enter the left heart circulation, and from the left heart they may go to brain, they may go to kidneys, they may go to any place else, and now person is in deeper trouble. They may have stroke, they may have kidney failure or something like that. So always need to pay attention. There is no fistula, it's not leaking back into the heart. Okay, only then you inject particles. If you see this leak back, then we talked about, then we need to put coils. Okay, because coils are bigger, they won't leak out into the left side of the heart and still provide you that hemostasis. So these small technique things, they matter a lot. So how good is bronchial artery? Because we know that bronchoscopy is not that useful when the person is bleeding that much. Other options are not there. Surgery mortality is very high, 40% or so. But bronchial artery actually is very, very helpful. Immediate success rate is up to 98%. If done right. Only issue with that is that there may be a long-term recurrence. What happens, you have blocked one artery, but their underlying problem is still there. TB is there, tumor is there, cystic fibrosis is there. That's not going to go away till you specifically treat that. So there will be another area of bleed. Okay, so recurrence can happen because of that. Or the material which you have injected into the blood vessel, it gets recanalized. You block a pipe, and now the pipe starts leaking again. So you have to do it again. But even doing it again, it's not that hard, and if you do it right, it may last for a long period of time. So as I said, recurrence would happen because of incomplete embolization or recanalization, or there is a backflow, intercostal arteries feeding into that, or something else is feeding into that, or progression of the basic lung disease. Okay, because till you get rid of that diseased lung, it's going to come back again and again. Then each medical procedure, as it has some positives and some negatives. So there are always chances of complications. So chest pain after bronchial artery embolization is quite common. So patient will complain of my chest is heavy, or there is chest pain. It's very common, but usually transient. What typically happens, the person comes with hemoptysis, bleeding is on the left side from the left lung. You do embolization. As soon as you head out of the room, patient says, my chest is hurting, and this is on the left side. Immediately people start thinking about cardiac issues, and cardiac workup starts. But sometimes you take a deep breath and tell them, this is transient because of embolization, it will happen, let's see what happens in next 2 to 3 hours. Typically it resolves in half an hour or 45 minutes. Then dysphagia can happen because some of these vessels, they join with the mediastinal vessels, and there is esophageal and other anastomosis too. So dysphagia can happen, again transient. If patient complains, I can't swallow, sounds very alarming, but typically it goes away. Other thing which is more of because of the technique, because you are trying to find a very small vessel which may not be visible on CT or anything, so you are searching quite a bit, so you may scratch the aorta a little bit. Okay, so subintimal dissection can happen, okay, which looks pretty dramatic, but actually it heals on its own. So that flap, because it's downgoing, it typically closes itself. Then other things, bronchial necrosis can happen because bronchial arteries are supplying bronchi. So if you're too aggressive, there may be an ulcer in the bronchi, but very rare. Okay, and typically in the esophagus there can be a hole or something, but these are more of case report kind of thing. They are not even 0.1% of the whole picture. But one thing which is dreaded and which leads to many medico-legal cases is spinal cord ischemia. Okay, so whenever you are doing bronchial artery embolization, in my department, I have a separate clause added to the consent form that spinal cord ischemia can happen. Okay, without us doing any negligence or anything, spinal cord ischemia can happen, and we will talk about that. And this incidence is 1.4 to 6.5%. So this is not trivial. Okay, it's rare, but it can happen, and it's because the anterior medullary artery, the spinal artery, the anterior spinal artery, which we call artery of Adam-Kivix, it shares an origin with bronchial arteries. Okay, so in this angiogram we are seeing two types of vessels. So this is left bronchial artery, okay, and then these vessels, bronchial artery should go towards the lung, okay, but these vessels are coming back to the midline. Okay, so but if they have this configuration, these are radicular branches, so they go up to the level of the spinal nerves, not beyond that. Okay, if you see this pattern, this is not so bad, but if you see this pattern that they are going even further out, and more importantly they make this kind of hairpin loop, okay, the hairpin we use for keeping hair in place. If it's making that hairpin loop and the artery goes straight down and down and down, that is anterior spinal artery. Okay, if you see that, that is a major thing, because now you want to be extra careful that whatever embolization you do distal to that, because if these particles go here, they are going to affect the spinal cord. Okay, that's the most important thing. And the spinal cord ischemia would look like something like this on MRI scan. Number one, person will become paralytic. That is bad. Number two, the management options are there, but they may or may not work. Typically, if you see that, we immediately drain the spinal fluid. We try to decrease the pressure in the spine upon the spinal cord. You can give steroids, questionable use, but it may help. And then we want to aggressively anticoagulate them, so this artery will start flowing again. Okay, so if you see any signs of these, first thing is prevention. If you see that artery back flowing, you need to be very cautious. Or if it sometimes you don't even see that and it happens, then you need to be prepared for all these things. That is something you need to tell the patient or family upfront that, hey, this can happen. So that protects you medico-legally a little bit. So this is just a flow chart, how to localize and do all these things, but we talked about that. Only one thing I would say before stopping, that if there is sarcoidosis, then actually the prognosis of these patients is bad. If they start bleeding, then you do embolization on top of that, then actually the necrosis and erosions actually worsen. So their survival rate is just 4 months or so. But without sarcoidosis, if you do bronchial artery embolization, 78% of patients they survive 5 years, which is pretty good. So I will just show this last case because we talked about that. So this was HIV patient, and that's why he got this large cavitary lesion. And in the cavitary lesion, we have this nodular opacity. So what's the name we talked about? Rasmussen. So this is classical Rasmussen aneurysm, So you see a nodular lesion which is bleeding into a cavitary lesion, that is Rasmussen's aneurysm. And now in these patients, we see that on imaging, we know that this is coming from the pulmonary artery. So now we will go to the venous side. Okay. So we are coming from the inferior vena cava, the right atrium is here, the pulmonary artery is somewhere here, main pulmonary artery, we are going into the left pulmonary artery, and there we see this aneurysm. Okay. And now with the help of micro catheter, we are going very close to that aneurysm. So this is that pseudoaneurysm. So that cavitary lesion, because of TB or fungal infection, that vessel eroded and now it's bleeding here. So this is very classical. And this is just more examples of that. So let's stop here for any questions and comments.
Wonderful talk. We have lost 1 or 2 patients where we were not able to get. Young patient with dengue and all, septic shock and everything. He improved, but later on started bleeding.
Right.
9-10 साल पहले की बात है सर, 9 years back. जब वो लगता था कि he will not survive now, he survived. But at the end of the day, when he was about to discharge, before 1 day before,
massive.
We tried with हम लोगों ने फिर सर से हेल्प ली थी, ब्रोंकियल आर्टरी में किया था सर, हम लोग मिला कुछ नहीं था उसमें. तो somehow I don't know. Maybe it was from the trachea itself or somewhere.
Right.
We tried with to see localize the bleed from the bronchoscopy also.
Right. The main challenge is technological. You can't see.
We can't see.
That's the main challenge, Yeah.
So I had a small query. Suppose an OPD patient comes to you with a history of hemoptysis, and that's like 4-5 episodes in the last 4-5 days.
Right.
And you do a CT scan, you find some lesion over there. So do you recommend bronchial artery angiography in such patients? Because many times these patients are bleeding on and off.
Right.
If you don't have an actual bleed happening during the angiography, you don't see anything.
Yeah.
So how do we give them some statics and they stop, and then they again come after another 1 month.
Right.
So these things keep happening, and you have a lesion, but they're not bleeding. And then
Right. So we covered that point. Number one, on angiography you won't see anything. But on CT scan, if the measurement is more than 2 millimeters, and which side is bleeding, I typically prophylactically embolize them.
okay.
So I go back.
Normal vessel, normal size.
Yeah. So if it's about 2 millimeters and they have history of hemoptysis, and you are sure it's coming from the left side and that artery is big, you just embolize that. So in many cancer patients, because TB is rare but cancer is very common, so we get these patients all the time. So typically that's our protocol. So we know that they are going to bleed again, we just embolize them.
So basically in India the problem is like in esophageal varices now. If somebody is alcoholic, you have to do a serial endoscopy every 2 years or 1 year down the line, depending on severity of the alcohol. तो उसमें endoscopy लोग they are not going for the endoscopy.
Right.
So here if you tell them that this is 2 mm and we should okay, तो कहता है liver bleed आएगा तो we'll see.
That's the biggest that's the biggest problem.
और तो हमने बोला ठीक है भाई देखेंगे.
Right.
जब तक वो बीमारी नहीं हो रही थी तो
Right.
Once they are in emergency only then we'll go for
Right. And
they agree for admission with hemoptysis sometimes.
Right. And I think that's where the community education comes, that we need to tell these guys, आज तो रुक गई है, लेकिन 3 महीने बाद फिर होगी एंड वी मे नॉट बी एबल टू डू एनीथिंग.
नोट्स सडनली नोट लिख दो कि ब्लीडिंग हो रही है, हो सकती है, जाना है, डिस्क पे चले जाओ.
हाँ. So education, some patients will still be like that, you know, कि जब होगा तभी आएगा. So that problem is there. That problem.
In case you remember from your experience, the one you told with spinal ischemia.
Right.
Anticoagulation just after embolization, how
Right.
did you went about it?
So now we
The risk of bleeding again.
Right. So it's a very fine line, you know. So typically we start with spinal tap. We try to reduce the pressure. We give steroids, you know, and about 75% of cases they improve, you know. Typically we don't start anticoagulation right away. So we wait 24 hours, 36 hours. If no improvement, then we go for that.
So that is the time.
That is the time.
To buy time initially.
Buy time. Right. So we almost never we start, heparin right away.
Right.
Yeah, right.
My question was like in emergency situations when a patient comes with hemostasis and you told most of the patient die because of asphyxia.
Asphyxia.
And if you are lucky enough to localize in situ that this side is bleeding,
Right.
is there any role of separating the lung?
Yeah.
You separate?
We separate the lung. Almost always we separate the lung, you know. Some patients will come like cystic fibrosis, you know. So they get bleed, every 6 months or so, and we know which side is bleeding, Pediatric patients, So those patients they need, protection of the lung for sure. Okay. Older patients who are well compensated, sometimes we do it quickly because in experienced hands, it's very quick procedure. You can be in and out in about 45 minutes, But if you anticipate that there is going to be problem in localizing, for example, 80-year-old patient. So now the aorta is full of plaques, and you are trying to find, bronchial artery. So it's going to take some time. In those cases, we do the protection. Yeah,
Like
always.
our setup, we can buy some time by
Right.
separating the lung.
Separate. Yeah. So I think that's crucial. Yeah.
So you people are putting double lumen tube or bronchial purpose?
Double lumen tube. Yeah. Again, it's an aesthetic, choice, what they want to do, but typically that's the, yeah.
Thank you very much, Dr. Sandeep.
Thank you.
I would like to share a few interesting cases. I think we'll just discuss about
Okay.
them. Like you mentioned about separation of the lung.
Mhm.
We started a technique called physiological lung exclusion.
Okay.
That is published in a European journal also.
Mhm.
And then we published one article in the Asian Annals.
Mhm.
So we had a patient, he was 82-year-old and he had massive hemoptysis, and on angiogram there was a pulmonary artery aneurysm.
Okay.
So that was arising just beyond the region of the right upper lobe branch,
Mhm.
and it was dissecting into the lung,
Mhm.
and it had already ruptured into the
Mhm.
lung, and it was bleeding heavily.
Mhm.
So the cardiologist that time I was in Fortis, and they thought that the region is too wide for anything to be put to block.
Yeah.
So what we did was that we took the patient for a thoracotomy, and on table it was very difficult to identify the pulmonary artery because there was the blood had dissected all across.
Right.
So what we did was that we ligated the pulmonary artery
Mhm.
just beyond the region of the upper lobe branch,
Okay.
and we also blocked the bronchus.
Okay.
And after that the bleeding also stopped and the patient also recovered.
Mhm.
So we have been using that technique for those patients who have massive hemoptysis,
Mhm.
and sometimes in tuberculosis also when the entire lung is stuck.
Mhm.
So if you can't take out the lung, because if you try to take out the lung, it keeps on bleeding
Right.
all around.
Right,
And
right.
sometimes you may lose the patient on the
Mhm.
also. So we can block the artery,
Mhm.
and if we block the bronchus,
Bronchus also. Okay.
so that we devised that technique as a physiological exclusion of
Mhm.
that part of the lung.
Right. Yeah. Basically, both the pedicles are gone.
So
Yeah.
we have done around 5-6 such
Oh,
cases.
okay.
And then I'll share Dr. Sudhir, he's the director of cardiology here, and we had very interesting cases. Last year one of them was post-COVID, and that was a mother of one of a doctor only, and she had like dyspnea, and saturation started coming low. So when the X-ray was done, so there was a huge opacity on the left side, and then the pulmonary angiogram showed that there was a AVM. So it was on the left side, and it was a huge like communication. So then Dr. Sudhir, like he thought of a, like I think you put a ASD device.
So actually, it was a very rare anomaly. It's a LPA to LA.
Okay, so massive shunt.
Right. Likely to be congenital, but
Right.
only
Wow.
come to the fore because of the COVID.
Right.
And in the literature, we have not found another case.
Acha.
It happens in children sometimes, not in adults.
Right.
But it was a massive thing.
Okay.
So we thought of putting coils and all, but
Right.
the flow was so torrential.
Right.
We knew that they are going to migrate to the from there into systemic. What we did was we took an ASD device,
Okay.
right? We just pushed it inside and just pulled it.
Okay.
So it became like
Right.
and it totally occluded.
Well, okay. Yeah, I don't know if we have a case. Yeah, we did almost similar thing. We used an Embolic
Yes.
plug,
Yeah.
Right. So we used an Embolic plug, and that sometimes. So you see, so there is a massive.
Yeah.
So this is after Swan-Ganz actually, So the pulmonary artery aneurysm is so big, And what to do with these cases, So in this case, I don't have that, but we put it Swan-Ganz,
Right.
and we just filled it up,
Right.
Right. So, and then, these are, so this is Behçet disease case actually. So in Behçet disease again, the pulmonary artery aneurysms happen, because of inflammation, and they can get very big, So now again the problem is if you put a smaller coil, that will flow back into the left side, So in this case, we actually started a coiling here, so we created a sort of rope,
Right.
scaffolding, and on that rope we attached this bigger plug, so it won't go away. So, but these are challenging cases, so.
You had the child also.
And we had another interesting case. So Dr. Sudhir, he referred the case to us that the patient had AVM, 10-year-old child, and it was a huge AVM on the right lower lobe.
Okay.
And there were too many arteries supplying that AVM, so it was not possible. Like we had a discussion, and Dr. Sudhir thought that
There were multiple arteries.
they were too big and too tortuous arteries,
Right.
so it was not possible to embolize. So then we saw the CT and we did the 3D reconstruction, and we tried to figure out from where the main supply is coming. So there were like large arteries, tortuous ones, and one was covering the superior surface of the main AVM, and one of them it was coming on the inferior, and there were multiple from all around. So we thought that we'll do a surgical resection. So we did a VATS, and then we tried with the bipolar cautery that if we can isolate the big arteries, then maybe we can separate the aneurysm part. But when we were trying to touch, like they were so tortuous and vascular that it was torrentially bleeding. So what we did was that because we had done the 3D reconstruction, so I had a basic idea in my mind that what is the location of the lower lobe pulmonary artery from each of them. So then we did a segmental section in which we used a linear cutter. So we just made sure that we don't cut the pulmonary artery supplying the lower lobe.
Right.
And,
but strip kind of.
But we just removed that segment, and all the feeding vessels they got clipped. So after that, like patient had very dramatic recovery, and before surgery, the patient had a saturation of around 80%,
Right.
and there was frank clubbing
Right.
and cyanosis.
Mhm.
And within couple of weeks, like the
Yeah.
saturation became more than 95,
Right.
and the clubbing also started vanishing in the follow-up. Like he's been coming for now almost 3-4 months.
Right.
I think more than that. 6
Right,
months,
right.
and that
Clubbing.
cyanosis has vanished.
So that means shunting is gone. Yeah.
And
No, that's
X-ray
good.
comes clear now.
Right.
Another interesting case was that we were referred a case which had a huge kind of a aneurysm type of a swelling in the right lower lobe.
Mm-hmm.
So on pulmonary angiogram, like we saw that the blood was collecting, but we're not able to localize like from where it was coming. But few feeding vessels like we could see,
Mm-hmm.
and when we opened up through video assisted only, so we tried to aspirate that.
Mm-hmm.
We aspirated 20 ml, and again it filled up.
Mm-hmm.
We aspirated another 20, again it filled up.
Mm-hmm.
So it was not possible to like go around it because it was huge, like
Big.
almost a little smaller than a football. And then we saw the feeding vessel. There was some vessel coming from below the diaphragm also.
Yes.
So we first ligated them,
Right.
and then we went all around and ligated all the
Right.
feeding vessels and removed.
Right.
And then we sent for this histopathology,
Right.
and we were surprised that it came as a tubercular. So maybe it was a giant Rasmussen gland.
Right.
So we never imagined.
Yeah,
that
it could be Rasmussen, but with sequestered lung,
Sequestered, yeah.
sequestered lung. So supply is coming from below,
And it was
Yeah.
like immediately filling.
Right. So it was sequestered lung, and because of that, TB settled there. Yeah. Right. Interesting. Yeah.